Have you
Kushbu, look alive.
There?
I am.
Okay. Hello, everyone, and welcome back to another episode of the Core Consult RX podcast. My name is Mike Corvino. With me, as always, Cole Swanson. Plus, we have two special guests, Kushbu and Christian. What's up, y'all?
Hey, guys.
Hello.
And y'all can totally move the mic around, too.
Yeah. Feel free.
We want you to participate. So, Kushbu and Christian are both fourth-year pharmacy students at MUSC, the Medical University of South Carolina, and they are starting their fourth-year rotations. Stuck with me. So that's the reality.
Not a bad way to start.
Yeah. So far we're 2 for 2.
Yeah.
This is my second group of students this new school year where I forced them to be in the podcast.
Right. Hey, you want to come over and watch a podcast? Sure, we can do that.
Yeah, for sure.
Uh-oh. Here you are.
So, yeah. So tell me a little bit about y'all's selves. I said y'all twice, so in case you guys didn't know from before, I'm from South Carolina, so I'm allowed. Kushbu, go first. Ladies first.
All right. So as Mike said, I'm a fourth year. This is actually my first rotation, luckily with Mike. And it's going pretty well. We had a crazy week last week, so this week is a lot more chill. So I don't know. We'll see what the year has in store for us. So.
Why was it crazy?
Yeah, what was that?
Well, you had the plague.
Yeah, Mike almost died last week.
Yeah, he almost died. He wants everybody to know that too. So.
Yeah, I didn't, but that's fine.
We thought so.
I was out of commission, so that's why the Instagram and all that stuff like that was down for like a week. It was terrible.
But we are back, baby.
Back and up.
Mm-hmm.
Or something like that.
I don't know.
But
you made it up.
Kushbu, so what's the plans after graduation?
I actually don't know yet. I figured with each rotation, I'll be able to kind of figure out what I want to do and basically hoping for the best. Either I'll get a job or maybe residency. So currently looking into acute care, but we'll see. And retail as well. So
awesome.
Very cool. Also, I'd like to point out we're live on Instagram for the first time. We're using the new and improved Apple TV, so we can actually see the questions.
Right.
That was the big dilemma on how we were going to go live.
Peering at the phone way over there to try to read it.
And Blake's watching us now. Blake's on rotation with me next month, so that'll be good.
He's learning.
He's learning.
He's getting ready.
He's getting ready to see what's coming.
It's the preparation.
Learn those trials. Oh my God.
Yeah, there you go. Trials. So Christian, man, what about you? What's in your future?
Yeah, so this is my second rotation. My first one was general, like internal medicine with the VA, and now I'm here. I think it's probably the best way to start off your fourth year. And then after fourth year, I'll plan on doing like general PGY1. Haven't looked into a ton of programs yet, but probably going to look mainly in the Southeast region.
You're pretty interested in like critical care and stuff too, right?
Yeah,
like,
definitely. Yeah.
Thinking that route?
Yeah.
That'd be cool. So you'll be a lot smarter than us soon. Very soon.
Very soon. Like some people we've had on the podcast recently.
Yeah, because you watched the ones with Brian Gilbert, right? Listen to the podcast and he just on sepsis and all that.
Yeah, I saw a little bit of the sepsis one, and then I'm doing my grand rounds topic on he mentioned the trial that recently came out, like the differences between the crystalloids and so forth. So
that's cool.
Awesome.
So today we're going to go over gout, and bear with us if we've kind of covered some of this before, because we don't remember if we've covered it in depth.
We haven't done a whole podcast on it. We know that for sure, but it's that's about all we know. But we've definitely touched on some stuff like uric acid level goals, stuff like that, and I think even the febuxostat trial, but we're going to go all into it later on, so
yeah,
buckle your seatbelts.
Oh man, it's going to happen.
It's going to be good.
Yeah. We're also going to try something where we actually write down the topics that we've covered.
Yes.
And so that we're aware of what we've already covered, and we're going to keep it a lot more organized going forward.
While repetition is a great way to learn, we don't want to be redundant.
Yeah. Plus, we also thought that we'd only do this for like 5 episodes and people would kick us off of Spotify and iTunes. And so since it hasn't happened and the viewings and downloads and keep going up, I guess we'll have to get more professional with it.
A little organized.
Yeah.
We don't like being organized.
Yeah, Cole's in charge of that.
That is my job. Anyways, we're talking about gout. So interestingly, gout is an extremely old disease. I'm sure all you guys heard during your lecture, your professors probably brought up that it was the disease of kings because it's associated with purine-rich foods, excessive alcohol intake, which was associated with royalty back in the day. But it goes back much farther. The Egyptians first identified it like 2000 BC, or actually 2640 BC. Hippocrates also talked about it in the 5th century BC. He called it the unwalkable disease for obvious reasons. And gout came from a Latin word, gutta, which means drop. The reason for that is because they used to think that gout was caused by an excess of one of the 4 humors. So once one of those humors was dropped into a artery, or it flowed into an artery, that would cause pain and inflammation. So that's where gout comes from. And colchicine is an extremely old medication. The uricosurics came around in the early 19th century. And now, of course, the modern treatment are NSAIDs and xanthine oxidase inhibitors, which we'll talk about.
Absolutely.
History lesson for the day.
Whew. And colchicine, from what I've heard, I've done zero research on this to back up, but I trust the source that I heard it from. Colchicine was actually brought here by Benjamin Franklin.
Is that right?
That's what I've heard. And
The turkey guy.
yeah,
He wanted the American bird to be a turkey, not a bald eagle.
bald eagle is such a better choice.
I know. Come on.
Yeah.
What
out
is
of
that
here.
guy
A
thinking?
turkey? I know. Ugh. Anyways, yeah, so supposedly he brought in colchicine from Spain or France, one of those European countries that were a lot more
across the pond.
yeah, they were a lot more sophisticated back then than we were. And apparently he suffered from gout, so brought it back and treated himself with it. So kind of interesting. But yeah, so where do you guys want to start? Acute flare?
Go for it.
And we talk about what gout is too, generally.
You're right.
I know.
What am I doing?
Which we got a nice little comment from somebody on iTunes that we don't skip over the basics, which is kind of a fine line to walk because we don't want to get too into the weeds about the basics of disease states and stuff. But I think it's good to give a little bit of a brief overview of what we're talking about before we get into the treatments.
Good deal. You want to cover patho then?
Sure. So gout, it's mainly characterized by urate saturation of the extracellular fluid. It gets into the joints and causes, like I mentioned before, pain and inflammation. A lot of times it is more specific to one joint, but it can be to other ones. There are a lot of risk factors for gouts that involve comorbidities, your diet, drugs that you're on. People will have acute flares. They can be recurrent over time. And you can also have chronic gout, which is usually associated with a tophaceous state or tophi, which are little crystal deposits of urate that's precipitated out and causes pain in the joints. That's generally what it is.
So, as far as seeing a patient present with this, they have a gout flare, even, first time, whatever it is, whether it's just recurrent or not, the biggest thing we want to do is obviously relieve the pain from the flare. I've never personally experienced it, but from what I hear, it is extremely painful. And I've even heard of patients having gout in like areas of, like the elbow and things like that,
right,
where I can't even imagine how painful that is. So we got to work on what we're going to actually do to treat the initial flare. And so we can either give colchicine, like Cole was talking about before. It's been one of the oldest treatments we've had for gout. What that basically does is it interferes with the neutrophils. It keeps them from migrating to the site of inflammation. And so you're controlling those chemical messengers, if you will, those neutrophils, so that when they get there, they never actually reach the site and increase that inflammation. We also can give just a general NSAID. Typically, we use either indomethacin or naproxen,
Mm-hmm.
And then we can also give steroids. So all three ways, we're basically combating inflammation, but they do 3 completely separate mechanisms of action.
Right. And there's a lot that goes into deciding what you're going to use. So especially in patients under 60, NSAIDs can be a better option. But as you get older, of course, there's higher cardiovascular risk, high risk of GI bleeds, drug interactions, and stuff like that. He mentioned naproxen and indomethacin. I think Sulindac is also FDA approved for treatment of gout.
Yeah,
as well.
it is. That's true.
Not
I
as
forgot
common.
about that.
A lot of people really like Indocin, but naproxen's good too. People even use Celebrex sometimes, but the most common are definitely naproxen and indomethacin.
Right. And the guidelines don't give us a direction on which way to go specifically. If there's not like different comorbidities kind of giving us an idea, they say to just basically, use the patient to target whether you're going to use corticosteroids, anti-inflammatory, or colchicine. They haven't ever actually shown that one is better than the other.
Mm-hmm.
So that's kind of interesting. You really can kind of pick one of the three. I feel like a lot of times, though, they do end up going with colchicine.
Colchicine is pretty common, especially if it's more mild and they want to do monotherapy. If it's more of a severe pain, you can add one onto the other. You could do colchicine with NSAIDs or colchicine with glucocorticoids, so you're attacking both pathways to the pain there. The treatment can go anywhere from a couple days to multiple weeks. It just depends on how well the patient's doing. Generally, you can look into stopping therapy 2 to 3 days after the resolution of the symptoms, but you may want to be a little more careful with the steroids. If they've been on them for a longer period of time, you'll probably want to taper it off over a week or so, and in select patients, you might even go over a couple weeks.
So as far as, we've treated, we get the patient feeling better, we cut down on the actual gout flare itself. Now we have to decide whether or not we're going to manage the patient and have them continue on some sort of maintenance therapy, or kind of wait and watch to see if they're going to have a gout flare again. And so there's two major guidelines that kind of deal with gout, and they're kind of conflicting, which is interesting. I've talked about this on Alexa, I believe, and a couple other things, but there's the American College of Rheumatology.
Mm-hmm.
They've had the guidelines for a long time, and then now we have the American College of Physicians that have also come out with guidelines that are a little bit contradictory. However, the rheumatology folks are saying that they're sticking with their initial guidelines and they're not going to change it up. So, one of the big differences is if you do decide to put the patient back on like continuous maintenance therapy, if they are at risk for having another gout flare, if they've had multiple flares, and you want to keep them on maintenance therapy, one of the first questions is, okay, well, do we need to treat to a specific uric acid level, right?
Right.
So,
and there are definitely arguments both ways. So uric acid levels are not the only thing that determines a gout attack. We didn't go too in depth on diet and all that kind of stuff, but diet, comorbidities are going to play major factors, and uric acid is more of something you can monitor to say, yeah, this puts them at an increased risk, or they might not be at as high of a risk. But patients have gout flares with normal uric acid levels all the time. But the goal, I don't think you mentioned the number, is less than 6 for the rheumatology folks. And the reason for that is because around 6.8, that's the solubility maximum, basically, of uric acid. So that's when the crystals are going to precipitate out, and that's where it causes issues in the joints and causes the pain and inflammation.
Right. And so, because there's some meta-analyses and things like that, like Cole was saying, that don't necessarily prove that decreases the likelihood of having a flare, that's the one that the American College of Physicians kind of threw out. They say that we don't have to treat to a goal level of uric acid unless, other than just kind of guiding therapy, guiding care. They don't have to, they don't have to set a certain number, because even when we do shoot for 6, it doesn't seem to correlate with outcomes of them having a flare, which seems odd to me. I mean, it seems very counterintuitive.
Because we like treating numbers. Like there's a lot of disease states where we want to get them to a goal, and it's like, oh, they're stable there. But I think it is reasonable for it to guide therapy. So if a patient is having recurrent attacks or they have tophi and you want to start them on maintenance therapy, I think it's a reasonable thing to say, okay, we'll use this as a goal. And we know that you're doing well if it's below 6, and that makes you lower risk, generally speaking, for a flare. And that's really all we can do with these urate-lowering drugs, those xanthine oxidase inhibitors and the uricosurics. Is they lower uric acid. They don't do anything for acute gout flares. They can actually even precipitate an acute gout flare, and we'll talk about that. But it's something you can use as a guide for sure.
Yeah. So 2 different schools of thought on whether or not we should be monitoring levels in general. One thing we didn't talk about is if you do decide during a flare, if you do decide to use colchicine, the typical dosing, they give you 2 tablets, and then an hour later, they give you a third tablet. So you have 1.8 milligrams. Colchicine comes as a 0.6 milligram tablet in the United States. And so they give 1.8 milligrams total over that first hour, and then that's it for the day. And then they will do daily or twice daily from then on out, kind of going forward.
Until the flare is done.
Right. Now, before, I can't really remember when this actually changed. I want to say it wasn't all that long ago.
No, it doesn't seem like it was.
But originally, they used to treat with really high dose colchicine. They would actually give around 4.8 milligrams over about 6 hours, different variations of that.
Yeah.
And what they did is they basically studied using the Agree trial. They studied 4.8 milligrams versus 1.8.
Right.
And wanted to see which one was more effective at reducing the inflammation from a flare. What they saw was there was actually no difference between the two groups. However, you gave the person much more severe diarrhea,
Right.
To add on to their pain from a flare.
I feel like we talk about a lot of medications that cause diarrhea. Colchicine is definitely a medication that
Yeah.
causes diarrhea.
Yeah, it's not great,
It's not good.
but
It's not fatty poo, but it's diarrhea.
definitely not. But it's probably better than having your foot feel like it's on fire,
I would think so.
or wherever the joint that's affected.
People describe, because it frequently the attacks will happen at night, and people describe just moving the blanket over the top of their big toe causes excruciating pain. So it's pretty intense. And colchicine, generally, you want to try to get it started within, I think you maybe mentioned the first 24 hours. Did you already say that?
I didn't mention that.
Okay,
no.
first
Good.
24 hours is ideal. Within 36
36
hours, it's fine too. And the reason for that is because at that point, the neutrophils have probably already made it to the site of action. So colchicine preventing them from getting there isn't going to do much. So post 36 hours, you're probably looking more into NSAIDs and glucocorticoids. I also don't think we mentioned that you can use parenteral glucocorticoids if a patient can take oral, or if it's really confined to 1 or 2 joints and you feel like an intraocular, I don't think intraocular is the right word.
That's eye.
Yeah, that's the eye. So if you think that an arterial injection would be better, then you can go for that.
Yeah, in the joint, arterial.
Intra-arterial.
So, Cole, for those of you guys who are not aware, Cole just passed boards, and so he has been studying for like 2 weeks straight of just nonstop pharmacotherapy. So his brain's fried.
Yes. Well, I thought about talking about glaucoma today, so that might have been where I was. Yeah, I brought that.
That was the
I
confusion.
did mention that. Yeah, probably so.
Shoot. Okay.
Oh well.
So bear with us, guys. It's Cole's fault.
Yeah, it's my fault. All my fault. You can blame the Naplex.
Yeah, stinking Naplex.
Yeah, that thing.
Ugh.
Gosh.
He crushed it, by the way.
It was okay.
Destroyed it.
It's a pain, but
Yeah.
it's not as bad as everybody thinks.
He
That's
said,
for sure.
100, get out of my face. I'm going higher. So he did awesome. Super proud of him. So, okay, so where are we at? So we got acute therapy,
We
and
got colchicine.
we got colchicine.
I did want to mention with the glucocorticoids, one concern that clinicians might have is with glucocorticoid therapy, it can mask some type of infection. So a lot of times it's hard to delineate between an acute gout flare and maybe an infection, especially if there's not tophi present. You have redness and swelling and pain at a certain site. Sometimes people think it might be a cellulitis, and if you give steroids, you're not really going to be able to identify that. It might mask it. So that's a concern that you would have to consider. As far as the diagnosis of gout, it's very clinical. So they don't draw uric acid levels during an acute flare to say, oh, yep, he has an acute gout flare. This is how we need to treat him. It's very clinically based, and they even have calculators that they can use to determine if this is probably gout, or, yeah, I think this is gout, or this is definitely gout. And that's kind of how they go about that.
Good deal.
Yep.
To what I miss. I had to step away for a minute to go deal with my dog who was
Yeah.
barking.
It's great.
For those of you who are listening and you're like, man, I feel like every other episode there's a dog barking. Yeah, I'm just going to go ahead and
correct.
address the elephant in the room. We've tried multiple things to keep him quiet, and somehow he always waits until we are mid-podcast. Good stuff. All right.
Stuff.
Where are we at?
You have anything else for acute gout?
No.
Okay. So, I mean, those are the mainstays: NSAIDs, colchicine, glucocorticoids. And when you're considering maintenance treatment. We already talked about it, but it's got to be recurrent gout. The patient, you can't get the uric acid level low enough, or they have tophi. That's probably going to be the biggest things that you're looking at for using urate lowering therapy long term.
If you have a woman that comes in that is currently pregnant, typically, so special circumstances of when to choose one over the other. If you have a patient that's pregnant coming in, obviously typically looking at glucocorticoid would probably be the best option. We don't want to give colchicine.
Want to give NSAIDs.
And NSAIDs, limited to the first 20 to 30 weeks gestation, but we would like to avoid them if possible anyway.
Right.
So glucocorticoids would probably be the best option for someone coming in that's pregnant.
Colchicine is also renally dosed. Something to consider. Allopurinol is as well, which we'll talk about in a second.
Colchicine is also not removed from or by dialysis. So a patient that is on hemodialysis should not receive colchicine either, because the dialysis machine apparently is not able to remove the colchicine.
Gotcha.
So end-stage renal disease, we would probably look at corticosteroids as well, and then the other ones we'd have to consider the risks.
Yeah.
What about anticoagulation?
Yeah.
So obviously colchicine probably the better option.
Right. If you have a patient who's currently being anticoagulated and you're worried about that.
Because NSAIDs you're worried about stopping the platelet aggregation, platelet adhesion, so you could increase the chance of bleed risk.
Yeah.
So just a couple different things to consider depending on your patient population. All right, maintenance therapy.
Let's do it. So the mainstay of maintenance therapy, like we said, are the xanthine oxidase inhibitors, primarily allopurinol. Febuxostat was considered an alternative before, but there has been some new data that's come to light that's showing some concern with cardiovascular risk, right?
Yes, correct. So basically what they did is they compared allopurinol directly to febuxostat. And I'm going to actually pull the article up here. Christian, do you remember if the article had like a cool name? Was it like Clear or something?
No, I don't remember. If I don't remember like a catchy name or anything.
I have a huge issue when the trial doesn't have a catchy name. I can't remember it.
They gotta have a catchy name.
But it was basically allopurinol versus febuxostat.
Yeah, they looked at about 6,000 patients with gout and major risk for cardiovascular disease, or they had a history of major cardiovascular disease, basically comparing allopurinol to febuxostat directly. Febuxostat showed an increased risk for cardiovascular events, and I believe an increased risk for cardiovascular mortality long term. So they're not really sure if that's because allopurinol actually has some cardiovascular benefit. Seems doubtful because there wasn't a placebo group in this trial, or if febuxostat had negative cardiovascular outcomes. But at this point, allopurinol, based on that, definitely preferred, and really, as an alternative, you would probably look more into the uricosurics before you would go with febuxostat, a different xanthine oxidase inhibitor.
Right. So the allopurinol, the like we said, xanthine oxidase. Did you talk about the mechanism behind that at all? So the xanthine oxidase inhibitor, you're basically blocking that last step in the pathway to actually create uric acid. I believe, hypoxanthine to uric acid, one of those. But you're stopping that last step, and so the uric acid is never actually forming, and so we're keeping it low, at the, low uric acid levels in the blood. Now, we used to never start allopurinol or febuxostat until the person had their acute flare resolved.
Right.
And the reason behind that was basically because if you think about your uric acid levels being high, your body kind of gets used to that. And so when you start to first lower those levels, there is a chance where when the levels are going down, that your body sort of sees that as your levels going too low, even though it's not really. And it solubilizes your uric acid stores, releases it in the blood, and it can actually precipitate out another gout flare.
Right, and they call that mobilization gout.
Mobilization gout, yep. And so, the thought process was fix the first flare so that you're not causing it to flare back up again and causing more problems.
And standardly, a large risk was in the first 2 weeks following an acute gout flare. So they would say, okay, so don't start allopurinol or a urate lowering therapy until you're 2 weeks out from that gout flare. Another reason is because during an acute gout flare, your uric acid levels are kind of all over the place. And if you were to draw one, it wouldn't be particularly reliable indicative of how your levels have been just chronically. So 2 weeks out is when they say, okay, you can probably get a reasonable level now and we can see where it's at. If your uric acid level is not elevated, then what's urate lowering therapy going to do for you?
Right.
Probably not much. So you would, in that sense, that would be an argument for waiting, drawing the level and saying, okay, uric acid level's high, we could get something out of this medication.
And, the way to combat that is if you were worried about precipitating out another flare, not being able to draw correct levels. One, if you're following the guidelines, say you don't need levels.
Right.
Obviously, it doesn't matter. And if you wanted to start allopurinol, which a lot of times it is started now during a flare, or at least right after a flare, you can give colchicine with that at the same time because you're blocking that neutrophil migration to the site of inflammation, and so the flare actually never happens because the colchicine is keeping all that at bay, if you will.
Right, and you can also prophylax with, I guess I should say alternatively, you could prophylax with an anti-inflammatory medication like NSAIDs or glucocorticoids. Colchicine just seems to be the most common.
Right, exactly. So, that's the big reasoning behind whether or not we want to start allopurinol in the middle of a flare right after.
And it also affects how you titrate allopurinol. So if you wanted to avoid that, you would probably start around allopurinol 100 and titrate pretty slowly. Standard doses are around 300 milligrams and max doses around 800. If you're prophylaxing, you could probably reasonably start around 300, but if you were worried, you could still start around 100. So it makes it that concern is much less when you're prophylaxing for mobilization gout.
Right. So we have allopurinol on board.
Mm-hmm.
Now, if the person is still having flares with allopurinol, that's kind of the big question is what to do now.
Right.
One thing that I've noticed is we very rarely actually push patients to max dose allopurinol or even anywhere close. The most I almost ever see is 300, 400 at the most.
Right.
The max dose allopurinol is actually 800 milligrams.
Right.
So, one, we have to consider, can the person tolerate going up on the dose? If not, then we have to consider what to do at that point.
Right.
There's a couple different ways of managing this, especially if the patient has things like tophi or other risk factors as well, have had multiple gout flares that year, then you can also give a colchicine, like a maintenance dose of colchicine, either once a day or twice a day at max, for a period of time, usually 3 to 6 months and sometimes longer, based on the patient risk factors. But that can be another way to kind of combat that reoccurrence.
Yeah.
The other option, we have other medications like the uricosurics. So probenecid is the one that is probably the most commonly used, and even that's very rarely used at this point.
Yeah.
It just basically increases the renal elimination of uric acid. Not something that we see a whole lot of. You would want to really avoid things like if a patient has a history of kidney stones.
Right.
We want to
put you at high risk for kidney stones.
Yeah, get rid of that. Even if it's a calcium oxalate stone, uric acid levels can still precipitate out calcium oxalate stones.
Yep.
So you want to avoid that. And there's actually a new kid on the block as well, and that is the URAT1 inhibitors.
Mm-hmm.
So Zarampic is
Lesinurad.
Zarampic is the brand name. This is something that again kind of increases the renal elimination of uric acid. However, we absolutely under no circumstances use it by itself,
right?
Because it can cause an acute kidney injury,
right? So you'd always want to have it with allopurinol.
Right. And that actually comes there's a brand name that has it in combination with allopurinol as well. The problem I have with Lesinurad is the data kind of backing it up is a little bit
weak,
sketchy. Yeah. It's there. I mean, you can you can debate either way with it, but it's a little bit weak. There's some question as far as why in the studies they didn't push the allopurinol dose higher. There didn't seem to be a huge correlation between patients that were having these acute flares already had uric acid levels. They weren't really at goal necessarily. So there were some different things of like, well, why didn't we optimize allopurinol? Why did we immediately jump to adding the Zurampic on at 300 milligrams? Because 300 milligrams is the minimum the patient can be on. You have to be on at least 300 milligrams of allopurinol before starting the Zurampic or Lecinerad. So there's some issues with that.
Yeah, that whole renal failure thing, not ideal.
Yeah, not great. Plus, it's expensive.
Yeah, definitely expensive. So really, after allopurinol, if they're contraindicated, which it's renally dose adjusted, I'm pretty sure anything under creatinine clearance of 60, you're going to have to start dose adjusting. So if they have renal failure, you're really in trouble as far as urate lowering therapy with the concerns with febuxostat, concerns with Lecinerad, and probenecid not being great in renal failure either.
Right. So, so febuxostat, the thing is, it's still brand name as far as I know. It's got some cardiovascular potential issues.
Mm-hmm.
That one is definitely one I would probably stay away from. As far as I know, we need to double check this, but I think it was the College of Rheumatology, maybe both guidelines have said they prefer allopurinol.
Oh yeah, I think they both
over
do.
febuxostat.
Yeah, but it is not renally dose adjusted, so that's like one of the few. So that was the big claim to fame for it for a while, but now we have other concerns. So it's a risk benefit thing at that point.
So yeah, you have to really consider whether or not we're gonna go ahead and treat with allopurinol febuxostat at this point.
Yeah,
I would say hold off on until you absolutely have to.
Yeah.
But and if you were going to, I'm just throwing this in there. This is not necessarily evidence-based, but if you're going to, if you can't use colchicine for whatever reason and you want to add on a second agent, using an NSAID long-term, not ever recommended, but if somebody was going to, I would say probably the better option would be naproxen instead of indomethacin, a little bit less GI upset.
Yeah.
I've heard of sometimes if you can't tolerate a NSAID, using celecoxib and using that instead. There's some data that shows, because the other issue with celecoxib was we were worried about cardiovascular risk for a while, and that there was the Precision trial came out basically showing that there wasn't a difference between celecoxib and naproxen or ibuprofen in regards to cardiovascular risk, but they stated that it was had a better and safer GI profile. When you dig a little deeper through the supplementary material, you realize that the only things that were really driving that benefit were constipation and iron deficiency from a GI origin. So not anything really all that big a deal, but that is another option if a patient can't tolerate a long-term NSAID. But I would definitely argue to not use an NSAID period, but if you just have to do that and you're really worried about them having another flare, then naproxen would probably be a better choice anywhere in regards to long-term compared to the other NSAIDs.
Yeah, seems reasonable.
I don't know, threw that in there.
Yeah, so that's chronic management. Right?
Yeah. And so, again, we have the uric acid levels either being less than 6 or nothing at all. No levels.
It's up to you.
It's up to you.
Suit your fancy.
What guidelines you want to follow. And, yeah, just kind of managing the other risk factors.
Yeah, and the other comorbidities are really important. We didn't really talk about that much, but hypertension, primary central hypertension especially, is definitely associated with gout attacks. In particular, when you're being treated with a thiazide diuretic, that can increase urate levels and increase your risk for a gout attack. And in more particular, hydrochlorothiazide is known for doing that. So it's minimal, but it can definitely increase your risk. For me, that's just another reason not to use hydrochlorothiazide. Some say that you can negate that by using an ACE or potentially an ARB like losartan. So losartan actually has uricosuric activity. So if you were had a patient who is high risk for gout, and you've got them on some other stuff, and it doesn't seem to be working, but you're treating their hypertension, consider losartan. But if you have a patient who's high risk for kidney stones, or they're having kidney stones and they have no other risk factors, but they're on losartan, that could also be an issue, because just like probenecid, it can increase your risk for that.
Yeah, that's a really good point. And if you have a patient that is having kidney stones and gout flares, and you're worried about both, allopurinol would definitely be the best maintenance there, because you're going to reduce the actual concentration of uric acid to begin with, and so it's never actually reaching the nephron to be filtered out and precipitating out a stone. So definitely allopurinol. And there's actually some that will use, some patients that will be on low dose allopurinol just for kidney stone prevention. Not done very often, but there is cases of it.
Yeah.
And I think it's not just HCTZ that increases uric acid levels. I think it's all thiazides.
I think they all do. Yeah.
Yeah. So,
I think HCTZ, just because it's been studied more, is known for it, but they all do.
And that's the big one to watch for, is the thiazide diuretics.
Yeah.
Do loops decrease?
I saw loops.
Loops, do they increase uric acid?
I saw that they increase
absorption. Yeah. It's the calcium that's the opposites from
right.
thiazides and loops.
Right. Low-dose aspirin as well can increase urate levels. It's not necessarily a reason to stop somebody's baby aspirin if you are, especially for secondary prevention, even for primary prevention, but it may at least make you reconsider whether they need it, consider if they're really in that beneficial age group and risk factors, and consider taking it off. It has kind of a paradoxical urate increase at low doses, and then if you get like really high daily doses, it has uric effects. So if possible, it's not really recommended in gout. And then obesity is another big risk factor, so it's a risk factor for everything, and they recommend like 3 to 5 pounds of weight loss a month to decrease your risk for gout. So
so that's gout.
That is gout.
And if you're curious about obesity, we have an episode on weight loss drugs.
We do.
Yeah.
Harken back to that one.
I do know about that one. You guys have anything to add?
No, it's kind of late, but going back to diet, I know you had mentioned like the diet. We actually learned in class that vegan diets can also cause an increase in gout flares. Yeah.
Really?
Yeah.
And they say why? Because that would be a little counterintuitive, because of like the meat products and all that is what's known for it.
Yeah, no, I don't remember exactly.
Fascinating.
I just remember, vegan diet being one of those things that can increase the chances of gout. Yeah.
Interesting. Coffee apparently might be associated with it, and they say that the DASH diet, well, they don't say, it's been studied in a few small trials, can decrease your uric acid levels. So we like the DASH diet overall. It's probably just because it helps with your blood pressure, I would think.
So let's see. I'm trying to pull up uric or purine. High purine foods.
Yeah, so generally I think of seafood and meats primarily.
Right, and I want to say that there is some vegetables as well.
Yeah.
So for completeness sake, since we're finishing early, I'll go ahead and pull this joker up.
Yeah, you say early, but it's not like we have a time limit.
That's a good point.
We just go till we're done.
So alcoholic beverages, high purines.
There you go.
Stop drinking so much, guys.
I know. What are you guys doing?
Duck is moderate purine for all of you who enjoy a nice duck
A nice
dinner.
duck every once in a while.
I don't know that I've had a lot of... organ meats like liver. Ooh. Where's the vegetable component? Maybe I'm totally making that up.
We'll do that in...
We'll do it.
We'll let you guys know
Instagram.
what we find.
For sure.
I'm sure there's something out there.
Yeah. All right. What else? Anything else we should cover?
That's all I got.
High purine vegetables. Studies showing that high purine, such as asparagus and spinach. But studies are suggesting that they do not increase the risk of gout or reoccurring gout. But I'm sure that's debatable.
I love asparagus.
Do you?
Yeah.
Not a fan. Man. Spinach is good.
Not a big fan. All right, Popeye.
Yeah. Well. Some of us like to be healthy.
As he sips on his monster.
Yeah, as I sip on my monster. Total hypocrite. All right. Well, thank you guys for hanging out. Appreciate you being here.
Glad to have you.
Cushboo, look alive.
There.
I am.
Okay. All right. So we'll catch you guys next time. Also, thank you for the comments. We've gotten a couple emails from people with suggestions, and we definitely appreciate those as well. If I have not emailed you back, I apologize. We're trying to get to everybody, but we get messages on like multiple platforms.
Which
is
we
what
like.
We
That's what we want.
yeah, we do
We ask
encourage
for
that. I'm just sometimes we are, with everything else we have going on, very, very slow to answer back. So if I haven't gotten back to you, I apologize. Cole also apologizes. He's very sorry, but he had to
Very
pass boards.
sorry.
So,
I had to do that thing.
and yes, so thank you so much for the comments, questions, concerns, all the stuff we've gotten. And let us know if you have any topics you want to cover. We're going to try to have some more guests on pretty soon with
Got some people lined up.
some distance guests. But yeah, thank you guys for supporting us, and we've noticed the downloads and all that have gone up pretty significantly lately, so we're very, very thankful for that. The fact that anyone wants to hear what we have to say is pretty humbling.
Pretty awesome.
But yeah, so thank you guys for that, and we will see you next time. Have a good one.